Ese es el país.
Yeah, much better. Yeah, it's fine. Yep. All right. So let's get started with today's talk. So we have Professor Sandro da Rocha. Da Rocha. From Brazil, actually. So Professor da Rocha is a full professor in the Department of Pharmaceutics in the School of Pharmacy at Virginia Commonwealth University, VCU, and also a full member of the Massey Comprehensive Center at VCU. He obtained his bachelor's and master's in chemical engineering from the Federal University of Santa Maria and Federal University of Santa Catarina in Brazil, and his PhD in chemical engineering from the University of Texas at Austin. After a postdoctoral fellowship in chemistry and biochemistry at the University of Texas at Austin, Dr. Da Rocha, now I learned, started his tenure as assistant professor in the Department of Chemical Engineering at Wayne State University in Detroit, Michigan in 2002. He moved to VCU in 2015 and is the founder and current director for the Center of Pharmaceutical Engineering and Sciences, and also the PhD in Pharmaceutical Engineering at VCU. All right, thank you very much for coming to Colombia. It is a pleasure to have you today in this talk.
Thank you so much. I appreciate your welcome.
Absolutely.
This is a mic for people remote.
Yes, that's the
Thank
microphone. You can just
Okay. Can you tell me?
Yeah, it's working.
They can hear me? Okay. All right. Thank you so much for welcoming me here at the university. I appreciate this so very much. I love this type of interaction. I love science, of course. And it's a great pleasure to be here to tell you a little bit about what we have done in the many years that I've been teaching. So it's been about 20 years that I'm a professor. And so having said that, I'm sure you understand that we have way too many slides that we put together always. So my goal here today is not to go through all the slides that I have prepared, but that we have a conversation. So I'd much rather that you guys stop me and ask me questions. Tell me what's on your mind. If you see something here that is exciting to you, just raise your hand and tell me, ooh, how about that? And we'll talk a little bit more about what interests you, not what I had prepared for you, okay? So that's very important. Please stop me, feel free to ask questions and to redirect where I'm going with the story, because the story is 20 years long and we can knock over in 50 minutes.
Right.
So having said that, let me see a show of hands here. Who works with nano in the audience? Okay. So this row here, most, okay. Yep. Whose research focus is on cancer? Nobody? Okay. All right. Okay. So I think the relationship then is, of course, there isn't a single person here that hasn't been affected by that directly or indirectly with family members or friends. So I'm sure you're going to sympathize with this idea that we need to develop new therapies to treat cancers. And today, what I'll talk about with you is this combination of nano pulmonary, so coming from the airway side to treat cancers, particularly lung cancers, both primary and metastatic lung cancers. Most cancers, when metastasize, they end up metastasizing to the lungs as well. So, and this is simply because one of the ways in which tumors metastasize is by releasing tumor cells into circulation, and those get stuck into the capillaries, and then they have an opportunity to form niches in the lungs. So it's not only primary lung cancers, but majority of the other type of cancers will metastasize to the lungs. Okay, so of course this is of relevance, and I'll tell you a little bit more about relevance in a minute. But what I will tell you today is this. The journey that you see here is about designing a nanocarrier system, and this can be applied to any nanocarrier, but I'll tell you about dendrímeros, and I'll tell you why we were so interested in dendrimers as a nanocarrier system of interest for us. I will have some introductory slides, so for people that don't work with nano, I'll get you set up and hopefully excited about nano. So I'll tell you how we went about designing these nanocarrier systems using in vitro and in vivo models, and then I'll show you an application of how we use that knowledge to address tumors in the lungs in vitro and in vivo. Real example of that. And then how do we formulate these nanocarrier systems for us to use the oral inhalation route to address lung tumors. At this specific moment, we are focused on, and I'm not presenting this here to you today, but I'll give you just a little bit of a flavor of this. We are working with the type of tumor which is osteosarcoma metastasis to the lungs. So osteosarcoma is the most common primary bone tumor, and at the time of diagnosis, 20% of the patients are also diagnosed with metastasis to the lungs, and the lungs only. The other 80% of the patients, meaning the 100% of them, are expected to have micrometastases that, if you don't take care of, will lead into gross metastases, and then survival cuts down 5-year survival from 70% to 20% when it forms metastasis to the lungs. The primary tumor can be cured, but the one in the lungs cannot be cured. So there are models in which pulmonary, and I'm just justifying pulmonary now, there are models in which pulmonary makes a lot of sense. Thank you. And other models in which we hope through this osteosarcoma studies that we're doing, we could pledge that to other types of tumors as well, as for example, lung cancers, in which usually they are diagnosed at the metastatic state. So you do want to go systemically, but going locally to the lungs will make so much sense. And the reason is the following: when you administer chemotherapy in many tumors, that's the standard of care, still chemotherapy, even though immunocheckpoint inhibitors that came to the market, they can be curative, meaning cure cancer. The percent of the population is still very small, maybe 20% of that type of disease. So there's the other 80%. So that other 80% is still benefiting from chemotherapy. But when you administer chemotherapy, do you guys have any idea what is the percent of the drug that ends up into the lungs? So if you're trying to treat lung cancer, guess. Just guess a percent of the total dose. Huh?
20%.
20%. Who gives less? Like an auction, 5. Who gives less? 3% in the lungs, not into the tumors in the lungs. So what happens to the other 97%? The rest of the body, exactly. And what is that doing? And we call that off-target effect, right? So that off-target effect. And why is that those free drugs can cause so much havoc?
I think that, for example, in chemotherapy, normally attack the cells and destroy them. It depends on the concentration of the body.
Right, but how do they go from systemic circulation into the tissues? How do they get there? So, right, so the capillaries, what happens with the capillaries what are the cells doing there? They're forming junctions. What is the size of those junctions? Huh?
Nanometric.
Nope. Who gives less?
Nanometric.
Nano?
Correct.
And what size is a small molecule drug? Angstroms. So those things can leak through very easily. And that's when nano can help us when you go systemically, because those are much bigger than that junction or endothelial junctions. And when you hear about the successes of nano, including it does better in terms of its pharmacokinetic properties, better in terms of its distribution, this is where this is coming from. Okay, it's just a matter of size. So now we're hiding the drug, and that big blob is going through circulation and it's not leaking out so effectively into the tissues that you don't want this to leak out. Up to today, there's one drug, which is a combination chemotherapy that's been approved maybe 5-6 years ago in the US. Just one has been shown to be more effective than the free drugs. All the other approvals of nano, and there's some drugs which are second generation generic, so it's old stuff, old school like me. So it's been there for a while. All of them have been approved because the patient's benefit comes from being less toxic, not because they were more effective, but because they're less toxic, okay? And we're trying to change that. We're trying to make things that are not only less toxic, but more effective. And so we're moving from that first generation type of nanocarrier system into more advanced systems, and dendrimer is one of the many examples of that, okay? So that's sort of like my story here in words, and hopefully I'll show you some slides. But I have already told you what I wanted to tell you, so now we don't have to really cover all the slides, okay? Now, this is a quick outline, but I'll jump into the introduction, which is about VCU. So I wanted to tell you who we are, and I'll tell you in terms of the research. Let's see if I can get the laser pointer. Okay, for people, huh? Yeah. Okay, thank you, yes. Because I was not able to connect that before. Hold on. It's locked. Okay. I don't know. Yeah. All right. So we are located in the state capital of Virginia, which is in Richmond. We do have some campus outside that. And we, in terms of research, 2025, I think we're close to 600 million in terms of research expenditures. We're very between top 2 and 3 in the state. We are the only 2 comprehensive cancer centers in the whole state. In the country, there are very few as well. And for me, this is a great benefit because of the infrastructure and the support system to do cancer research. We are the most comprehensive health science in the whole state. So we have all the health science programs, dentistry, physical therapy, medicine, pharmacy, etc., nursing. It's not advancing now. I think it froze. Okay, thank you. We are the only public school of pharmacy in the state. So everything that is related to pharmacy and pharmaceutical sciences happen at VCU. The other schools that are research intensive, they don't have those programs. Our research in the country in terms of school pharmacy varies between 15 and 20. I think this year is about 20. We have a PhD in pharmaceutical sciences, and the only PhD in pharmaceutical engineering in the country is also at VCU in our program. We have about 28,000 students. You said 20 here. We're about 28,000 students, quite a bit of professional and graduate students. These are the health sciences programs. Our endowment is about $3 billion. How do you see endowment here?
I have no idea because we also call it endowment.
Okay.
We have our endowment actually in your week. Yeah, Morgan.
Okay. Yeah, so this is our endowment. It's about $3 billion now.
So it's not that big.
Okay.
That's for sure. Yeah.
So this is a picture of our health science campus at a night and a day, during the day. This is our engineering and undergraduate campuses. I have some of the buildings for the School of Engineering. Richmond is a really beautiful city. I hope you have a chance to come visit sometime. This is where we're located, city of Richmond. We are about 2 hours south from DC, Washington, DC. We are 2 hours away from some of the most beautiful mountains in the whole country, and 2 hours away from the beach. So it's just perfect. During COVID times, my wife and I would drive to the beach for the day, and just be able to forget what was happening during that time. And we could do this during the day. So that was really great. And here I have some of this images, including this, which are the Blue Ridge Mountains, which are some of the most beautiful again in the country. night picture of Richmond, which the Richmond itself is about 300,000 people, but the metro area is about 1.3 million. And again, it's the state's capital. All right, so come visit us if you're in Richmond. I've just learned someone is going to be in Richmond very soon, so he'll come back and report to you how beautiful Richmond is. But yeah, honestly, if you're in the area, I'd love to show you around. So just come and connect with us. You can find me online and come say hi. All right. So when I talk to my students that are starting the program and to everybody else outside our lab, I want to really make sure that you understand that what we're going after. And what we're going after is to this idea of either delaying the onset or overcoming drug resistance in cancer. And the reason why this, particularly lung cancer, the reason why we are so interested in lung cancer, there's a big issue and there's a personal issue. My dad was diagnosed with lung cancer and I decided to go into that route. But it turns out that is the #1 killer, cancer killer in the US for both men and women. So more than breast cancer, lung cancer. It's not everywhere. I don't know here in Colombia.
It's probably third.
Third? Okay. Yeah. I recently been to Saudi Arabia and I was so proud to talk about lung cancer there. They told me it's #8 or 9.
8.
Which for me was a huge surprise with all that sandstorm and all the smoking. Go figure, right? I told them I'm going to import their macrophages. We do a lot of studies with macrophages, so if something is happening to their macrophages, I'll have to work on that. And of course, the issue of metastasis to the lungs. So not only primary lung cancer, but metastasis to the lungs is very important. But the key thing here is that not only for lung cancers in primary and secondary, but for all tumors, what really kills about 90% of the patients is the development of drug resistance. Okay, so I know you're not pharmaceutical scientists, so I'll tell you this. You remember that 3% I told you that we need, gets into the lung, into the tumors? There's something called a therapeutic window. Whenever you take any drugs, and those, they tell you to take 2 tablets because within the systemic circulation that is in equilibrium with the tissue of interest where you're targeting, you need to be within a concentration so that you can see the pharmacodynamic response, which is treating the disease, right? So you need to reach that window. It has to be below the minimum or above the minimum, below the maximum, because if you're above the maximum, it causes toxicity. And I'll relate that back to nano. But you need to be within that into the tissue of interest, in the cell of interest that you're targeting. Okay. So what that means is that when you're coming with small molecules to target those tumors, you need to keep ramping up the dose, ramping up until you can reach that therapeutic window into the solid tumor and reach the cells that are into that solid tumor. I'll tell you a little bit more how complicated that structure is and how it works to prevent this from happening, and then the development of resistance. But then there's some miracle drugs like doxorubicin that will kill any type of tumor in vitro. You get the tumor cells, you put on a plate, and you put that drug in contact with the tumor cells. It'll kill any tumor cell. The problem is that because they distribute so poorly into the tumors, particularly in the lungs, they're not even used to treat lung cancers, okay? Because you kill the patient before you kill the tumor of the dose you need to administer. And that comes that reason again why we'll be interested in using nano, because the big problem with toxicity is that maximum dose that you get into systemic circulation. So you ramp up the dose to reach that therapeutic window, and that maximum concentration is really what causes toxicity. Now, what we can do with nano, we can control the way in which this drug is being released from within that nanocarrier system. So you don't have to go such high doses, but you can still reach that therapeutic window into the tumors. Okay, that's how we get around that issue of toxicity with nano. I'm in slide number 2, and I use maybe half of the presentation, which I don't mind, honestly, because my slides, everything is published, so you can go there and not everything, but most of it is published. So you can go there and figure it out, and you're going to forget about it anyways. but there are a few messages that I need you to take with you, and I have already covered them. So we could stop now and go have some coffee if you want to. All right. So this is how we handle solid tumors. We try to play with the immune microenvironment, and I will not talk to you much about immune microenvironment today. But the reason that why tumors develop is because our immune system cannot keep those tumor cells in check. Okay, there's a very good chance that this is happening to me. My cells are going havoc, but my immune system is there to take care of them, and the tumors don't grow. But when that doesn't happen, then the tumors start growing. So there's a lot of interest in playing with that immune system so that they can take care of the tumor cells. Because when the tumor cells start growing, they are changing their phenotype in a way that prevents our immune system to take care of them. And that's how immunocheckpoint inhibitors work, which are this miracle type therapies. Say, for example, for lung cancers, there are certain immune checkpoint inhibitors that would cure lung cancer, cure metastatic tumors. So this is just truly amazing. The issue is that this tumor microenvironment here, for most type of tumors, is sensitive, maybe 20% of the population or even less. So for us, sarcoma is only 5% that are responding to that type of therapy, okay, of today's therapies. And we are focusing on these things called macrophages, which are cells that are infiltrating from systemic circulation monocytes. So you guys have all that background, right? Okay. Yeah. Right. Okay. So when we talk to chemical engineers, it could be a little different scenario, right? Yeah. So that's why I ask you where they're coming. So bone marrow monocytes circulating, and you have chemokines, cytokines calling these monocytes to infiltrate into the tumor. And when they get into the tumor, they usually change their phenotype into macrophages, but of the phenotype that is pro-tumorigenic. So it helps the tumor to grow. It sucks. In the lungs, our alveolar macrophages, which are not derived from the bone marrow, they also infiltrate and they play a role as well. So there are two types of macrophages that go into the tumor. Both of them help the tumor grow. And we have an opportunity to change their phenotype to a phenotype that is anti-tumorigenic. And that's what we're studying in terms of the tumor microenvironment.
Excuse me.
Yes.
May I ask, why does the phenotype of the
Macrophages?
I forgot the name.
Macrophages?
Yeah, macrophages.
Uh-huh.
Why does it change when it goes into a tumor?
So because of the tumor cells and other cells, including cancer-associated fibroblasts, they are releasing signals to favor them to continue growing. Okay, just like as, for example, when the tumor cells start dividing, the immune system, particularly T cells, are coming to the tumor cells to take care of them, to basically induce apoptosis into those tumor cells. But then suddenly they start changing the phenotype to start expressing certain types of proteins onto the surface that send do not kill me signals to the T cells. That's how they avoid that. And immunocheckpoint inhibitors are coming and they're blocking that and allowing then the T cells to come and destroy the tumors. But again, so this is like a miracle type therapy, but not for 100% of the patients, maybe 80%. And the proportion of T cells into those patients in which the therapy doesn't work, very, very small. We call that cold tumors. Macrophages are always the most abundant immune infiltrates into the solid tumors, but they're working against us, but they're very plastic, so we can change their phenotype. Okay, and that's what I'm not going to talk about today. So this is what I'm not going to talk about today, but we are looking into small molecules. We're looking into immunocheckpoint inhibitors for macrophages in tumor cells. We're looking at mRNA type therapies, all in the context of coming into the lung side, which gives us this unique angle, which is coming pulmonary, nano, and immunotherapies is something that there are not many groups that are working with. So that's our sort of niche type of research. But this is very important. And now I can see most of you really paying attention to what I'm saying. So I know some of this stuff is going to stick, and that's all I want. So we combine that with nanomedicines, and the reasons is what I mentioned to you before. We can hide the therapy, and this could be a small molecule, could be a biologic. For example, RNA, the issue breaks down very easily, right? So you can protect the cargo, but even for small molecules too, like we work a lot with gemcitabine, and gemcitabine is easily degraded, but we can hide gemcitabine within this, and we prevent certain proteins to come and degrade drugs. So it could be small molecule, could be a biologic. And these nanomedicines allow us to manipulate the interaction between this drug and the physiological environment because we're hiding that chemistry. So once the chemistry set of your drug, and do you have a medicinal chemistry program here?
Not really.
Not really.
In the chemistry department, there's
Yes. Okay. Yeah. So these people spend their lives designing these molecules, but once the chemistry is defined and they have optimized the molecule, that's it. And there's an area of science which is called pharmacokinetics. I don't know if you study that or not. You do? Okay. All right, great. So this is what the body does to the drug. And if the drug chemistry is fixed, that's it. It's going to be a repeat unless your physiological environment is different from you, which it is, but variations are small, or you have a disease, which will change that as well. But it's fixed. And the nano helps us to disguise that so that we can actually change the way that this interacts with the physiological environment. Yes?
But then the design, so it's not toxic to the body, like that particle. You can get toxic, or how do you design it to that?
Yeah, so this is a great question. How do you design these things so that they're not more toxic than the drug or the disease itself? Yes, and it's very, very important that you do so. And there's some rules that we understand. So for example, our most recent work that we're trying to push to be closer to clinical translation than our original work in dendrímeros, we are using lipids that are endogenous to the lungs. So if you get to make your nanostructures with composition that is the same as the tissue that you're delivering to, the chances that this is going to be highly biocompatible increase. Okay, but then there are limitations into what you can do with those systems. So then you try to advance a little bit. And then we have a continuum of potential strategies to advance this. So for example, stuff I'm not going to talk about here today too. And this is fine. So some people call me Dr. Tangent because I was like, okay, but it's fine. It's fine. We need to make this fun, and I need you guys to listen to me, and I need you to pay attention to what I'm saying. So I'll do whatever, Okay, I'm flamingo now. So for example, we have such systems that would be compatible, and we know this in humans for daily administration for 18 months. Okay, this nanocarriers that are of composition of the same as the lungs themselves. We have that, but then we have limitations in terms of the type of carrier system we can design, how good they are to treat the disease of interest. And then we have, and for example, gemcitabine I mentioned to you, and that would be sort of like the very most elementary nanocarrier system we can make. But say, for example, we can load maybe 3% gemcitabine into that system. Very, very small drug to carrier ratio. And we don't have much control of the way this is released. So lots of issues with that. Biocompatible, but we cannot optimize this very well. And then we have things all the way to the other extreme. So for example, we got this drug, a chemotherapy. And so I had the unicorn in my lab, a polymer chemist. And so his answer to this was, let's get the drug and we're going to functionalize that in a way that we made a monomer, and now we polymerize this. So now we made the polymer out of the drug itself, and then we can engineer a nanocarrier system out of that. And then there's so much more control we can do. But this is clinically translatable, more easily clinically translatable in one end, and the other carrier system, it's a much longer path to achieving that. So you have to balance. And then we combine this with local lung administration for our systems. And again, the benefits are this, 3% if you go systemically. If you go locally to the lungs, we can get maybe 60%, 70% of the dose. and they're not going directly into all these other tissues. But depending on the chemistry of the drug, and again, now I'm going to poll you guys, how fast do you think a drug that you deliver to the lungs can cross into systemic circulation? And give me a length time scale. Yes, seconds. Huh? Milliseconds. You got it. Okay, it's almost as if it's an IV infusion, depending on the chemistry of the drug. Now, if I'm trying to treat lung tumors, and these things are going directly through the lungs, that doesn't help very much, unless I have metastatic sites, which, okay, that's good. And we have seen that when we deliver chemotherapy to the lungs, we can actually reach metastatic sites and decrease that burden in distant tissues, which will be okay. But still, these things are not getting into the lungs. So it's a problem. They're not staying there. I can get them there, but they're not staying there. Well, so let's go back to nano again, okay? Because I can modulate that interaction between those molecules and the lung tissues, okay? And that's the story that I have here. I don't know how much you're going to be able to get into that, but we designed a nanocarrier system that had toxicity that was acceptable, in vitro at least, and now clinical trials show that in humans as well, not our clinical trials, but clinical trials. And we got those carriers, and we were trying to understand how the chemistry of those carriers can impact the interaction of our therapies. In one case here, chemotherapy of small molecule, that doxorubicin miracle drug. How can that alter the interaction between that molecule and the lung physiological environment? So I can make decisions as to, okay, if the tumor is in the lungs, I want to design something that would stay in the lungs, hopefully penetrate into that solid mass, which is a big, big challenge, and lead to tumor kill locally in the lungs, not systemically, okay? Or at least mostly in the lungs, and then maybe some systemic if needed. Now, we chose to do this with dendrímeros for many reasons, but remember I was asking you about what happens to that chemotherapy when it goes systemic circulation, endothelium with that fenestration that is nanometer length scale, drug, angstrom crosses. So the same thing in terms of thinking of design of your carrier, nanocarrier for the lung epithelium. The lung epithelium is much more stubborn than your endothelium for good reasons, right? That's why people in California are alive, right? With all that pollution, that craziness, right? They're still alive because things cannot just go through like that. Of course, macrophages help that too, but we are protecting ourselves by having that epithelial barrier to be very stubborn. Okay, so we are still talking about 5 nanometers or so, but the protein junctions that are formed are preventing this from allowing stuff to go through, but 5 nanometers. So what is the size of, okay, the nano folks here, the size of, what kind of nano you're looking into?
Probably 10 and 30.
What is the nanocarriers? Gold nanoparticles, okay, yeah. So if you're using that, and you can use that for other things that is not therapy, but if it's for therapy, 20 nanometers, and you have that little thing, 5 nanometers, which way can that cross? Wait, no, it can. Not, and we call that a paracellular transport, right? Which other transport we can have through endothelial? Huh? So not for nano, so that would be a small molecule, right? So for example, doxorubicin is hydrophobic, so will cross through the lipid bilayer, and you have some ion channels that you can transport other things, or channels, like gemcitabine, for example, you have channels that can transport drug in, but it's the paracellular and the transcellular. So through the cell, so endocytosis, exocytosis, but that's super inefficient. Okay, so that's a big problem for you to get stuff across. And people have studied that in the past, and they have understood that, and this was based on biologics, that if you have a biomolecule protein, let's say, with sizes, hydrodynamic diameter, because that's what matters, right? We have water all around us. So if you just say geometric size, it doesn't cut. You have to talk about hydrodynamic diameter, which is your nano plus all the solvation layer around it, right? Okay, so hydrodynamic diameters that are above that 5 cutoff, things that you deliver to the lungs, things may, in this case, biologics, that's what they have done the studies for, may take days to cross. Things that are smaller in hydrodynamic diameter, that those 5 nanometers, it can be minutes. So size here is a big factor. And we were misled with those studies because our hypothesis going with the dendrimers was exactly that. If we make dendrimers that are much bigger than 5 nanometers, we can keep them in the lungs for days. And if they're smaller, they'll cross very quickly. And I'll show you how wrong we were. But we were funded because the way that I posed the hypothesis was a smart way in which I said, if they get stuck, we can treat these diseases. If they cross, we can treat these other diseases. So it doesn't matter what happens in the end. If our hypothesis is wrong, it's still going to work because we still have the answer to this. But I was completely wrong in my initial hypothesis. And I'll skip to that quickly. I'll say we have like, what, 5 minutes?
No, that's fine.
No, this is fine. I don't want to keep them here forever.
Like 30 minutes.
Okay, all right.
Okay, fine.
If you guys need to sleep. If you need to, oh, you know what? I have a good joke. So not a joke, it's a real story. When I figure out that I'll be an outstanding professor, I was subbing in for my postdoc mentor. He was traveling and he asked me to teach this quantum mechanics class that I was dynamics. 7 people only 7 crazy people were taking the class, right? And like this, sure enough, I got one of the guys to fall asleep while I was speaking. I said, I'm just the perfect person to be a faculty member. That's when I realized that. So if you need to snooze, no problem. Let me skip to dendrimer business. I talked with words about most of the stuff that you see here, and I'll move to dendrimer. So this is how we can depict dendrimers. Actually, this is a molecular dynamics computer simulations that we did, fully atomistic. So we have every atom in this big molecule is represented here. We just remove all the water around it, okay? So maybe it's easier for you to see here. And these things are hyperbenched. I don't know what they were, what part of my body they were.
No, it was your face. But yeah, I didn't look at your face.
Okay. So so these things are hyperbenched. Imagine like a tree trunk with all the little branches. And at the end of those branches, we have functional groups, carboxyl, amine, etc., that you can easily functionalize. So these things are a pain in the butt to synthesize because you have to worry about every step of that chemistry. So it's hard. But by the end of when you finish these dendrimers, they are actually the most monodispersed polymers, synthetic polymers that you can have. This is it. And of course, with all your pharmacokinetics, you understand that the size of these things impact the way that they are interacting in physiological environment and does distribution. So having something that has that monodispersed characteristic is very important. But not only that, things like this are about 1 nanometer, 2 nanometers. After we change their chemistry, 5, 8 nanometers. So we are right within that window I mentioned to you of 5 nanometers below and above that would allow us to control the interaction with that physiological environment. And so we chose dendrimers. And this work we started maybe 15 years ago. And we felt like would give us an opportunity to come up with this innovative nanocarrier systems for treating lung diseases. This is the clinical relevance. There is, I'll show you this. There is one study on phase 3, and there are 2 drug products. One is a vaginal gel, the other one is a dental application. That's it for dendrimers. All the other ones are in process here. When I started, there was one clinical study, which is the gel. It was still phase 1 when I started for the clinic. So there's clinical relevance, and I'll show you what this can do. So these are some of the outcomes of one of these dendrimers. It's a polyamidoamine. That's the repeating structure of that hyperbenched polymer system, which I should have said here, having these functional groups allow us to conjugate molecules of interest or complex with other molecules of interest. So for example, we can control the bond between the drug and the polymer, and with that, we can help decide when and where that is released. Okay, so that's a big deal. Instead of being encapsulated in the release temporal and spatial being controlled by what kind of interactions? So if it's encapsulated, what kind of interactions we're talking about? You take physical chemistry too, right?
No.
No? Okay. See, found the weak spot.
But
Yes.
they have
No, I'm joking.
like biochemistry.
Okay.
isolation.
All right. So I don't think I was talking to, was I? Oh, I mentioned this. Okay. So if there's any questions ever on your exam, including with this person here, because I already, I know I'll back you up. I know I'll back you up. If you don't know the answer to, you write this: because of intermolecular forces at interface. It's always right. Okay. And if people say no, you email me and you say, talk to Professor Da Rocha, okay? So write it down: because of intermolecular forces at interface, I'll back you up. Okay. So if you have a polymer and you have your free drug, so you have different types of forces we can call hydrophobic interactions, van der Waals type interactions, electrostatic interactions, right? So those are non-bonded interactions. But you can control that very well. The bonded interactions, it's chemistry that you're doing there. And you can control the chemistry. For example, we have some systems in which we have a peptide in which is degraded by a protein which is elevated into tumor cells. So yes, they will release other places, but very slowly, very inefficiently, and they will more efficiently be released in the space, the location I want to. Okay, so that control is really key for something like this. Dendrimers are not the only polymers you can use. You can use a variety of polymers, but again, they're the most monodispersed. And you can have polymer systems, and it goes to your question about safety. We have now dendrimer systems that are polyester based, so they're biodegradable. So, all right, this is the clinical relevance of this, just as an example. So this is comparing free drug to the drug conjugated to your polymer. In this case, docetaxel. It's another similar to doxorubicin, just a really amazing chemotherapy. And so they did a study with 27 patients in the clinic. And this is the maximum total dose. And for some weird reason, we do this in terms of per meter square of your body. So this is total dose per meter square. And this is what you see, free drug versus dendrimers. So free drug, T-half, and now I know you have PK, so you understand that. So T-half, 11 hours for free drug. When you conjugate to your dendrimer, T-half now is 103 hours, okay? Now you combine with that, with the fact that the free drug, Cmax, you need to deliver such a high dose, okay? So 2,400 nanograms per ml, free drug. And then with your dendrimer, the amount of free drug that you have is very, very small in the beginning. Okay, the same total dose. Now you get area under the curve. You see the difference here. But then this is really what matters, right? So in this case, 13 out of 27 patients had stable disease. Okay, but now it's important that you understand. Nice meeting you. It's important that you understand why it's so hard for you to approve new drugs in chemotherapy. Just imagine for a second you're a clinician and you have a patient arrives to you. The first thing that this clinician is going to do, let's go with standard of care, treat. Okay, eventually you don't respond, unfortunately. You go to second line therapy or rescue therapy, and you may not respond to that too. And that's when the doctor will tell to the patient, the physician would say, okay, now we need to look into experimental therapies. But now that resistance is already developed, sometimes they're resistant to begin with, even with first line. So the patients, these 27 patients that you get here, that you can recruit, they only come to that clinical trial after exhausted all the other strategies. So now for you to see a response, the bar is so high, right? And this is why it's so hard to approve new drugs for treating cancer, including nanosystems, okay? Because the type of patients you're recruiting are patients that have not responded to standard of care. Okay, but in spite of this, 13 out of 27 patients had stable disease, and then also benefited from low toxicity. Okay, so far I told you, and I told you that this things called nano can help us improve that pharmacokinetics that you understand by distribution. I told you that we can get things locally to the lungs, and that can help as well because we're targeting the tissue of interest now instead of going systemically. And I showed you some proof here that this works in humans. Again, we could be stopping now if that was the case, but I'll keep carrying on. And then I'll tell you the story of how wrong we were. And I hope you appreciate that very much as an engineer scientist. So do you remember a story I told you about size? Okay, so we got these dendrimers, polyamidoamine with amine surface groups, and we used this PEG to modify their surface chemistry so we could achieve hydrodynamic diameters that went from below 5 to above 5. Okay, so 5 nanometers and above, and then here below 5 nanometers. And our hypothesis was when we get this into the lungs, things that are above 5, they'll get stuck there. Things that are below 5, they'll be able to cross. Okay. Now, we did put a fluorescent probe so we can follow where these things were going, both in vitro and in mice. And we also measure some of the key quality attributes of these dendrimers, in this case, zeta potential. As you increase the amount of this polyethylene glycol, which is an inert molecule, you start decreasing the charge of these dendrimers. So this is an amine, so it can be protonated. And as you conjugate, you remove that ability to be protonated. There are fewer and fewer groups that are protonated. But wait a minute, here I haven't covered out of 36, I only have 25, right? So I still have 32. I still have surface groups that can be protonated. The thing is that this is a polymer molecule and it has ether groups that can actually interact with that amine and hide the charge. So that's why you see something here that is not positive, right? It's negative. So you still have those amine groups, but they're being hidden by those functional groups of the polymer that I'm conjugated to the dendrimers, okay? So 32 surface groups, 25 functionalized with PEG. This is the maximum density, and then everything in between that and 0. Now, the 0 here, all of them have about 2 fluorescent probes conjugated so we could track where they're going, but you can imagine that would be something like the drug itself. And later I'll show you the drug. So do you remember I told you about paracellular and transcellular? So this is it. But in the lungs, depending on where the tumors are at, you may have different types of physiological environments and barriers. So if you are in the upper airways, you have mucus. Luckily, you don't have that in the alveolar region, or else you couldn't breathe. It'll be very hard. You could, but it'll be very hard because you have that oxygen exchange. But in the upper airways, you have mucus that is trapping all those particles, viruses, etc. And you have this thing called ciliary, mucociliary escalator that is bringing this up, go digestive tract, right? So if you want to, for example, if your tumor is metastatic, like I mentioned before, from osteosarcoma to the lungs, it's not necessarily forming from the epithelial cells in the lungs. So that tumor that comes from systemic circulation can actually be behind that epithelial barrier. There's some nodules that can be exposed to the air side, some that can be behind that epithelial barrier. So it might be that I actually want to be able to modulate the interaction between our carrier and the physiological barrier to be able to reach the tumor. That could be examples of that, okay? So let me show you that if this is what I want to do, what kind of in vitro system can I start to understand the effect of the chemistry and size to the ability to permeate through that? So what we did was we got the cells that actually produce mucus. In this case, the student was so good, we actually have cilia that we picked up, which was kind of nice. And so we make that layer. Here it's very important, and a lot of publications, they don't bother too much about this, but not only for measuring this transepithelial resistance, but also measuring internalization. For every epithelial system, you need to have polarization. Because when you polarize, the apical side, the protein expression on the apical side and basilar side is different. The way that they internalize nanocarrier system is different. So if you have an epithelial barrier, you need to have it polarized, okay, for your experiments. So if you're trying to understand how much of your gold nanoparticles are going to cells, if it's epithelial barrier, you need to show it's polarized. If it's a monolayer, you need to show it's a monolayer, okay? So we made that, and we measured this thing called transepithelial resistance. And that's how we pick this point in which the cells multiplied and formed those junctions. And at that point, we say this is the best we can do in terms of this in vitro model to resemble what happens in vivo, okay? So now once we have this, now we have that barrier, model epithelial barrier, in which we can look at the effect of the size and chemistry in terms of their translocation in vitro before we go into mice, okay? And then that's what we did, and we measured permeability. So we have that little experiment here. So it's a cell layer, apical side, basolateral side. The only thing that these dendrimers can go from apical to basolateral is going through that barrier, okay? And we measure permeability, so the rate of transport across the barrier. And then here is as a function of the number of polymers in the surface group from 0 to 25. So 25 is about 8 nanometers, 0 is about 3 nanometers in size. And what we hypothesize is that for the biggest dendrimers, they will not transport very well. It's the highest permeability that we see here, exactly the opposite. And for the smallest system that was below 5, we said is going to go like crazy across this barrier, and it's the one that is least transporting across the barrier. And just so you know, this permeability here is, this permeability is, this is the rate similar to a rate of a small molecule that we know is crossing paracellularly. Okay, so we have one molecule that's small, we know is going through the air, and we measure the permeability, and we say this thing is similar permeability. So we have a good indication it's going through that junction, and it's the biggest guy in the block here. Okay, all right, so we decided that we needed to learn a bit more about what was happening, so we wanted to know how these things were getting into the cells, okay, as a function of chemistry. So we did the same thing. We look at all the different dendrimers with different sizes, and we measured, we measured the cellular uptake. So now we see exactly the reverse strand. And this is something very common. Most nanocarrier system, including the vaccines you took, that PEG layer that is essential to make the lipid nanoparticles for the COVID vaccine, they prevent or they reduce the cellular uptake. Okay, and it's common across all nanocarrier systems. So that made sense that this was happening. As we have more PEG, less is getting into the cells. And I'm not describing how we're measuring this. We don't have time. But it's just, yeah, this is what we did. We measured the amount that is getting in, both in terms of using fluorescence, but also quantify the actual, of the total dose, how much went in, how much you're finding. So this guy, after a certain amount of time, which is 6 hours, because this is T-half in the lungs when we do in mice. So it's 12%, and then this is just a few percent, 2 to 3% getting into the cell. So we went back and then we said, okay, what's happening to those junctions? Because this transepithelial resistance is a surrogate for how well the junctions are being formed. And then we thought, okay, well, the stuff that is pegylated is not going to interact with those proteins that form the junctions because those are overall negatively charged, and our PEG layer leads to a carrier system that is negatively charged, so there's no reason for them to interact. But the ones that are positively charged, they'll interact more strongly, and we thought we'll see this for the positively charged, but not for the neutral. But no, we see for both. Okay, so we did a lot of computer simulations, and we understand that that interaction between PEG and those amine groups, they are transient. So there is an opportunity for those guys that we think are negatively charged, but they transiently become positive in that region, and they can still interact with that. So that's our hypothesis at this point. Of course, we haven't shown that in a real system like this. So what is that we have? We have the knowledge now that if you have something that is pegylated and is negatively charged, oh, and I didn't show you this, hold on. I don't have the results here. Okay. So there's another component to this that you guys need to understand, which is this. We put these dendrimers into what we call a synthetic mucus layer, and you measure their ability to transport across that barrier. So we have cells, we have the mucus layer, which you can imagine is just like a entangled polymer with a lot of negative charges. Okay. That's what that is. So we measured that, and we saw that when you have a negatively charged or a neutral dendrimer, slightly negatively charged, -1, these things cross very effectively through that mucus layer because it's negatively charged, they don't want to be stuck there. They can cross. But as I showed you here, when they see the cells, after they cross that, let's focus on the one that are highly pegylated. Negatively charged, slightly cross the mucus. When they see the cells don't want to interact with that, don't want to take them up very efficiently. So then the only resort is interacting with that cellular junction that we see they're doing, in spite of what we hypothesized in the beginning that was not going to happen. And they can open those junctions. And then when we remove them, those junctions recover. So it's a transient, is not toxic. It's just at the moment is leading to that opening the junctions. So if it's pegylated, it's crossing not because the size is large, but because of their surface chemistry. If I have something that is positively charged now, we showed in the mucus layer that it gets tangled up there because positive, negative charge. So it takes time to go diffuse through that. When the cell sees them, what is covering the cells again? What layer is that to cover the cells? Do you remember? Glycocalyx. And then you have lots of, it's the hairy thing around the cells. You see the images from a cell biology book. You see that little hairy layer around it, okay, glycocalyx. That's largely negatively charged. So these positive charged things interact non-specifically with that glycocalyx, and they're internalized. So they prefer to internalize. They don't diffuse very well, so they don't have an opportunity to cross as efficiently. So what's dictating, the moral of the story here, what dictating is not size, but surface chemistry. Okay, that's the moral of the story. And we did the same for in vivo, and we measured their disposition upon pulmonary administration. So we got these dendrimers, we delivered to the lungs, and we observed the same thing, that if you have something pegylated, we can find this to permeate through the lungs much more efficiently in vivo, get into systemic circulation compared to something that is positively charged. We also look at overall tissue distribution, and that's something really cool that we found, which is that when you go pulmonary, the tissue that uptakes most of these dendrimers after the lungs are the lymph nodes. If you go systemically, you don't get anything in the lymph nodes. And this is really important because now if you're thinking about using this, say, for a vaccine, maybe you can get your peptide vaccine. We're not thinking of a protein to dendrimers, but maybe a peptide. You can get your peptide to hopefully go into the lymph nodes, and maybe you can come up with a vaccine, pulmonary vaccine instead of systemically. So there was a lot of really important stuff here. Beautiful drawings. We can design dendrimers that we can actually get into the cells and direct them. We can control based on chemistry which cells within the lungs they go to. At intracellular level, we can also send them, say, to a mitochondria instead of nucleus. This is very important if you want to repurpose your drug. You can do that, and we showed, depending on the chemistry, we can do that. We showed that we can control how they diffuse into the tumor mass, which is also very critical here because we know molecules like doxorubicin, even being that small, they get entangled up. But if we change the chemistry, the nanocarriers can bring this all to the core of the tumor. And this is one of the ways in which the tumors develop resistance. The drugs don't permeate that far in that therapeutic window you can reach, and you develop resistance. So, and I'm going to jump here to the in vivo study. So we got these dendrimers, we conjugated to a drug, and we established tumors in the lungs. In this case, is melanoma metastasis to the lungs. So we have free drug and conjugated to the lungs, free drug conjugated systemically. Okay, and we compare the results of that. And this is the image that I want to show you, which is this. This is IV administration, PBS, so just a carrier system, free drug, and the conjugated. and this is if you come by a pulmonary route. Okay, and then here qualitatively you can assess that. So what you see here is that when it's IV, the drug itself, we were hoping to count nodules, but we can't. It's charred. All these black things you see there, they're tumors. Okay, if you conjugate this to your carrier, you see an improvement, but this carrier was not designed for systemic. If we would have had PEG, and this guy here does not have PEG. So we could have improved systemic circulation and done better if we had done with PEG, but we really wanted to compare with the pulmonary. And this was designed for pulmonary without the PEG. Remember I told you PEG helps to translocate? We did not want to translocate. So purposefully that did not have PEG. And then the ox was also conjugated with the liable bond here in this case. And then you see now if you come pulmonary, what you get. The number of nodules here, you can count now compared to before, this systemic, this is what you get. There's too many to count, the nodules systemically. When you compare also the free drug with the carrier system, you see that the free drug locally, because most of the drugs actually getting to the lungs, is doing a really good job compared to systemic. And then when we conjugate, we do even better. So this is really a major result that we had for this. Survival improved. But one thing that really made a difference here was that when we measured the amount of drug in the cardiac tissue, and that's the toxicity from Dr. Rubinstein, the dose-limiting toxicity is cardiac toxicity. When we have this conjugated to the dendrimers, we see that the amount that accumulates in the cardiac tissue is much, much less than the free drug. Okay. So not only coming from the lungs, you improve efficacy, but you also decrease distribution into the cardiac tissue with these carrier systems. We show that we can formulate them in different types of systems, metered-dose inhalers, dry powder inhalers. We also have some work with biologics. We have some nice movies. We're designing these carriers and how we change with the PEG, the interaction for you to make complexes, complexation. And we show that if you don't have PEG, the type of complexation much stronger. And if you have a lot of PEG, the type of complexation is much weaker. And designing this may make a big difference in terms of the release of this intracellularly, which is key, just like mRNA. In this case, we're working with siRNA. We can make them into dry powder inhalers, metered-dose inhalers, and that's it. So thank you so much for your attention. I appreciate the time you sitting there. If you have any other questions, I'll be happy to answer you.
Any other questions?
Yes, I was wondering, you said that we use polymers in this case, dendrimers, but I guess we can use any polymers.
Right.
How do we make sure that the polymers do not accumulate on the lungs over time?
Very, very important. So in this case, when we started, this were sort of like the best chemistry we could use, which was not great, to be honest. It's polyamido amines. As we move forward, you can see some of our publications. The year that the postdoc students synthesized this polyester-based dendrimer, which degrades, was the year that this company came commercial at the same time.
Oh, really?
So we could have benefited tremendously from his research, but the company came out with that. So the difference is this, that biodistribution and accumulation depends on the size of your care system. But if they degrade, then you recover very small fragments that will just go through the urine, right? So that's how you do it.
All right.
Okay, so you think of polymers in which you have bonds that can degrade, and then there's no accumulation in the end.
But the bonds have to be strong enough to, act as a carrier.
To stay long enough. So for example, if you deliver to the lungs, we know that T-half here was about 6.5 hours. So if your bond can last for several days, then we know it can do its job, but we know it's going to degrade eventually.
Right.
So that's how you control that.
Right.
Okay. Thank you for your question. You had a
So
question?
you were talking about that dendrimers were the market like targeting lungs. So these dendrimers can be used to treat like other diseases such as, for example, popcorn lung. I don't know if it's called like that in English. The one that is caused because of vape and all the process that it includes in the inflammation of the bronchioles.
Yeah, so the whole initial part of this project was understanding the effect of chemistry in lung disposition exactly for that. So our hypothesis was if I can design a chemistry that would cross the lung epithelium, I can treat systemic disorders, which is from the lungs. This is hard because, again, if you put a nanocarrier into the lungs with a drug, the drug may be released, go systemically, but then it's almost as if you're doing an IV injection of the free drug because the distribution, biodistribution in systemic circulation is going to be the same, right? The tablet or systemic or lungs, if it's just a free drug, the body has predestined to what is going to do to that drug. But with the dendrimer, if we can cross, then we can treat systemic circulation. So that whole idea of designing chemistry so I know what sticks into the lungs go across allows us to think about treating a variety of diseases, not only tumors, but that's our interest. And that's why I'm showing the work here. But it could be applied to a bunch of other diseases for sure.
Other question.
Please go ahead.
Shit, I forgot. Give me a second.
That's okay. That's
Give me a
okay.
second.
Okay.
Yeah.
So, I want to just tell you that I appreciate that you're seeing here and listening to this today. And I hope that a little bit of this stuck, maybe the major aspects of this, not these results you can go and find in publications, but sort of the major idea that these nanocarrier systems can benefit in treating important diseases because you're changing the way that the drug interacts with the physiological environment. Coming from the lung side can lead to dramatic benefits. And stuff I didn't talk to you here, but it's very important, is that if you can play with the immune system in that solid tumor, that can add to these benefits. Those are the three big messages for you. Yes.
Yeah, okay. So one question, you mentioned before that the research that you were doing right now was
Yes.
onto changing the phenotype of
Macrophages.
macrophages. I always forget the name of
That's
those
okay.
cells.
That's
Yeah.
okay.
What can I research more about that?
So we are doing something similar in terms of pulmonary nano, but instead of having a chemotherapy that is affecting the tumor cells, we are looking into how chemotherapy and other type of therapies are affecting the immune microenvironment or the tumor microenvironment in general. For example, gemcitabine, which is actually second line for osteosarcoma lung metastasis. So triple chemotherapy, first line when you have lung metastasis, response rate very low. When the tumor stopped responding, so there's no curative treatment. 40 years, we haven't been able to move the needle in terms of survival rate, big issue. So second line therapy is gemcitabine. When you go systemic, response rate is 5%. But when you go pulmonary, you can actually control the tumor burden dramatically, and you can change that response in a way that, it's just really incredible. And that's just the chemotherapy. There's a clinical study going on right now at MD Anderson in Texas. I was actually just there this Monday giving a lecture in our osteosarcoma project. We have a collaboration. And there's a clinical study on that, gemcitabine to the lungs. So what that is doing is not killing the tumor cells, but changing the phenotype of the tumor cells, because when they go from the primary bone tumor and metastasize to the lungs, they decrease the expression of this Fas ligand, which is a apoptosis marker for apoptosis. And the tumor cells, this is crazy because the lungs is one of the few tissues which constitutively expresses Fas receptors, the epithelial cells. So Fas receptor in epithelial cells, T cells, and Fas ligand in the tumor cells, when they connect, it leads to apoptosis. Very efficient primary tumor. When they metastasize and they understand the lungs are doing that, they downregulate that expression, then they start growing. That's how the tumor grows uncontrollably in the lungs. Gemcitabine epigenetically upregulates the Fas ligand, and then the epithelial cells and T cells in the lungs can actually lead to cell death, but it does not eradicate the tumor. It controls, and we have done 12 cycles of gemcitabine, and we can keep the tumor at bay so it doesn't grow anymore. Now, we cannot do chemotherapy forever in a patient, so that's a problem. So now we're coming with therapies that can actually alter the phenotype of macrophages, because we know when gemcitabine, and we have done some more recent studies, we know gemcitabine, when you treat in other tumors, and now we know in osteosarcoma, it leads to upregulation of certain type of proteins, particularly CD47, onto their cell surface. And the CD47, they send two macrophages, do not eat me signals. So macrophages are there, the good ones, which is just few in between. But even those cells in the minority, when they go and try to gobble up the tumor cells, which they do, they can't, because the tumor cells now elevate that protein as well. So we are looking into immunocheckpoint inhibitors for macrophages that will prevent this do not eat me signal, so that macrophages can do that. And at the same time, we're coming up with small macrophage immunomodulators that we have shown also can shift from that tumor promoting phenotype to the anti-tumorigenic phenotype. So we're hoping that this triple combination eventually would allow us to eradicate the tumor, which is really what we're looking for here.
What the next step
for this project here? So we think that we need to address this issue of pulmonary and tumors. The biggest barrier that we had was this thing called inertia. So doxorubicin is never going to be used in the clinic to treat metastases from melanoma to the lungs. And that's exactly why I use doxorubicin. Because when you talk to clinicians and you say, oh, I want to use doxorubicin to address melanoma metastases to the lungs, they'll say, but we don't use that. Well, you don't use that because you're going systemically. I'm going from the lung side. But because of inertia, it's too hard for them to understand this, because the issue is that if you have melanoma and you have metastasis to the lungs, then you have metastasis in other tissues, and they say, we'll have to go systemically anyways. Well, the answer, yes, we can. We should. But you know that the drug you're administering, only 3% is going into the lungs. So you are just developing resistance in the lungs, resistance. So why don't we combine pulmonary administration with your systemic? No, we can't do that. So inertia is a big problem. But with the osteosarcoma project, when we step back from primary lung tumors and metastasis to the lungs from other type of tumors, we step back now and we have a tumor model in which it metastasizes only to the lungs. Now talking to clinicians, it makes so much sense for them because it's only into the lungs. So we are in a huge detour to show that coming from the lung side is safe and it can be effective to treat lung tumors in a model that makes sense to the clinical community. Once we address that, then we can convince people to try our therapy into tumors that metastasize to other tissues besides the lungs, because now I know it's safe and effective, and I can combine with therapy for other tissues. And then I can come back to very complex system like this dendrimers to try and address this. So this is a huge detour because of inertia. But you also know that because of inertia, the size of a rocket ship is 2 horse asses. You know that, right? It's true. Ancient Rome, they paid toll to get their carriages across towns, and the carriages were being pulled by 2 horses, right? So now suddenly they invent trains, and what is the size, the width of the train? Okay, well, Rome had that width, so they made that into the width of the trains. Now suddenly you need to transport rocket ships, and you're transporting what? In trains. What size is the maximum size you can make a rocket ship to put inside a train? Well, the size of the train. So the size of a rocket ship is 2 horse asses. 2,000 years back, inertia. This is very, very powerful. And it's very powerful to all of us. Okay, so how much have you really changed it since you were born? Very little. I'm sure you still eat the same foods that your parents fed you from early on, and you haven't questioned that, right? So inertia is very, very powerful.
So based on what you said about the idea of this being a combined distribution system, Yeah, sure. This is useful on the case that we have metastasis to the lung. But would it be useful to administer the drug using intrapulmonar for any other organ, an organ that's nearby in
So-
comparison to, well,
So maybe not, maybe, okay, so for example, you can be successful in removing certain nodules in the lungs and it can be curative. But if that metastasizes to the lymph nodes, it's a problem because you cannot remove that easily. So if the dendrimers can actually biodistribute to the lymph nodes, maybe you could address that way. But then there are other diseases in which this will be important, coming from the lung side, that is not just cancer, right? Because you can have the whole carrier crossing systemic circulation. So this will be like a non-invasive way of
Okay.
delivering a nanocarrier system, because oral is very, very hard for you to get the whole nanocarrier system to transport via oral administration. So usually all the systems that are approved by the FDA, they're all systemic.
so how does this compare with the, well, intravenous administration?
Well, so in the case here, I'm showing you directly. So this is IV carrier system.
No, yeah, but in
Pulmonary.
this case, I meant more as a whole, like not for cancer, but for, well, other.
Yeah, so it's an ongoing development, right? And here is, you can see here, close your eyes for a second so you don't. Okay, here. So I have the stats here for also 2020. The number of studies just doubled, clinical studies. So there's a lot of people betting that this is a really good thing for a lot of diseases. And here I'm just showing cancer.
All right.
Okay, so there's a lot of potential in that. And the potential is such that, again, there's some of the early studies say this Doxil was approved before you were born. And now there are 2 generations of generic systems. Okay, so this is not new, it's old business, and very important business, as you can see here.
Yes.
Again, thank you so much, guys. I appreciate you being here today. Thank you for the interaction. Okay, sorry. Let's get out.